Hi, I'm Dr. Jason Lake with OrthoArizona Foot and Ankle Institute, and I'd like to take a few minutes to talk about Conor McGregor's injury over the weekend. A lot of you may have seen this. Of course, I'm not his physician, not treating him, so a lot of this is speculation, and I'm going by just the videos and photos that I've seen and my experience as a foot and ankle surgeon over the last 11 years. His injury was interesting because the timing of it to some extent. And I think before we talk about the actual injury itself, let's just talk a little bit about the anatomy of the lower leg. So here's a model that I have of kind of the ankle and lower leg. So the ankle itself and lower leg is comprised of 3 different bones, and then there's ligaments. The tibia itself is kind of your main leg bone or your shin bone, and that handles most of your body weight. The fibula bone is the smaller of the leg bones, and that's on the outer part of the ankle. And the fibular bone handles less of our body weight, but helps control more of the rotation. The talus bone is the bone underneath it, and that's what kind of moves up and down when your ankle moves up and down. And then we have collateral ligaments, ligaments on the outside, and we have ligaments on the inner part of the ankle that help make the ankle stable, as well as ligaments that run in between the tibia, which is the main leg bone, and the fibula. We have ligaments that kind of run up the center here. And that set of ligaments together is called the syndesmosis. So as we talk about this injury, I'll be referring to this model. So when he had his injury, he was kind of stepping back, and we saw a deformity happen as he stepped back. And we have to speculate a little bit why this happened, and probably the actual injury to the bone occurred prior to that. So the tibia bone is a very strong bone, but sometimes from repetitive use over time, you can develop almost a stress fracture type injury to the bone, no different than anything else. If you have a paper clip or a piece of metal and you start bending it over and over and over, eventually it'll get a weak spot and the paper clip will crack. And the same thing that can happen with our bones from repetitive use over time, which could be if someone's a runner, they could be landing on their foot a lot. In a mixed martial arts fighter, sometimes from repetitive kicking, there isn't a lot of cushion or protective tissue over the tibia. And so sometimes if there's repetitive blows over time, that's almost like landing on your foot over time if you're a runner. And a weak spot can develop, or even a crack of the tibia can develop. And most likely what happened from these repetitive kicks is he developed a fracture line running across the tibia bone. Then it became unstable, and then when you land on it awkwardly, then there was enough injury to twist through and kind of break the lower half of the tibia. And based on the deformity, he may have as well either injured the ligaments, or he may have injured kind of this fibula bone, which is the smaller bone. Now, where you injure them both or injure one and the other, that allows then there to be a deformity. Now, we don't know if he actually broke the lower leg bones themselves or if he had kind of a lower ankle ligament injury. And so when you have these are significant injuries that have significant recovery and are usually treated with surgery. When it comes to surgery, there's kind of 2 different approaches to stabilize these. And the point of the surgery really isn't to quote unquote fix the bone. Essentially, what we're trying to do is restore the alignment and the rotation. And then Conor is going to heal the bone himself. So the athlete or the person that gets injured, the body will heal bone. What we don't want is for it to heal in a crooked or a malaligned position. And so the surgeon's going to restore the alignment to allow the body to do its thing. And there's 2 ways to fix a lower leg injury. One way is to stabilize it with plates and screws. And another way is to kind of slide a rod down the center of the main leg bone. And if you look on the back here, this is the tibia. And if we look at it end on, the center of the bone is actually soft bone marrow. And so if the break happens to be higher up, sometimes we don't need to make big incisions down low. Sometimes we can actually slide a rod down the center, and that will help hold it stable without having to make incisions on the inner and outer part. The lower the break goes closer to the ankle, or if it involves the ankle joint, the more likely we are to have to make an incision, because at that point now we want to get that actual joint surface perfect, and it gets harder and harder to do without making some sort of an incision. And so that's when we start using plates and screws, the lower the break is. And so we don't really know exactly what level it is, but that's the main treatment option. Okay, so if someone does have a fracture to the lower leg bone, the tibia and or fibula, then we can fix them different ways depending on how low it is. Now, in this case, you can see this is what a rod looks like that comes down the leg, and I've kind of zoomed into the ankle itself. So in this case, the break was higher up. And if the break is a little bit higher up, that gives us room to slide the rod down and put screws across it to make it stable. Now in this case, it's hard to see. If we look really close, you'll see these little black lines in the bone. And in this case, the fracture was lower, and there was a fracture of the fibula and the tibia. So in this case, because the fracture went down lower and it involved the joint, we wanted to make sure that our reduction of the joint was more perfect. So we did make some small incisions. And we're able to slide a plate in there after we've reduced the breaks. And we've stabilized not just the tibia, but the fibula as well. Now, if the break is lower and involves the ankle joint and we have to use plates and screws, the recovery is still similar, which we'll talk about, but we can't let patients walk on it the day or the week after surgery. We're going to keep them off of it for somewhere between 3 and 6 weeks. And then we're going to start to allow really partial weight bearing using a boot. And we have to take things a little bit slower because these screws here, while it looks like there's a lot of them and they're strong, these are 3.5 millimeters wide. And so if you walk on it before the bone starts to heal, then we worry about screws getting loose or breaking. In this case, the rod is really big and it sits inside the bone and it's right in line with the weight bearing. So we can allow patients to walk on it sooner if the break is higher up and if we can fix it with a rod. But again, we're speculating because we don't know exactly what type of injury he has and the level it was. So when it comes to recovery for this kind of injury, it depends somewhat where the fracture's at. Typically, if an intramedullary rod can be done, we're going to allow the patients to walk on it sooner, within the first few days or even a few weeks. And a lot of times that'll have a walking boot. Regardless of whether there's plates or screws, there's not going to be a lot of strengthening and physical therapy allowed for the first 6 weeks or so, other than doing upper body and core and things to prevent deconditioning. And then once we start to see bone healing after about 6 or 8 weeks, then we can start allowing some low impact activities, standing, walking, and then slowly progressing. And so there's not really a lot of high impact stuff that's going to be done in the first 3 to 4 months, but a lot of cycling and strengthening and other types of stuff can be done. Usually by 3 to 4 months, there's enough bone healing, then we can really start getting after athletics. But the tibia will usually take 6 months or 9 months for it to really finish healing. But we would allow the patient to really start training more once we saw enough bone and the strength and the stability and the balance is back. But to get highly competitive and high contact, it could be 6 or 9 months before things are really good. Now, assuming the surgeon can get a good reduction and he's going to have great access to rehab, I would expect him to have a really, really good outcome long term and be able to return to activities. And this has happened in other sports as well. Paul George is a great example. But often, even when the patient returns for the season after it, even for the next year or 2 years, it takes the athlete a while for them to really get all of their balance and strength and coordination back. And sometimes they don't come back at 100%. It's 98% or 92%. But this was a closed fracture. The bone didn't go through the skin. And he's going to get immediate medical care. So I expect a good return from him. It's just going to be a while. Thanks for listening.